Hi, this is Scott Aldridge with Modus GI, and I'm here today with Dr. John Rabine, who is the Director of Gastroenterology Diagnostic Center and the Chief of the GI Division at Sinai Hospital in Baltimore. Welcome, Dr. Rabine, and thank you for joining me.
No, thank you for speaking with me today.
Of course. So I thought we'd maybe just start off by having you tell us a little bit about your patient population that you see at Sinai.
Yeah, we're a large inner city hospital, roughly 500 to 600 inpatient beds. We have a fairly varied patient population, primarily the local community, with some folks coming from the suburbs, but it's definitely an eclectic mix of patients. Many of our patients, though, will come from nursing facilities. Many of our patients are fairly ill. We do have a high acuity of patients here in terms of comorbidities. Their ASA classes tend to be all 3s and 4s, and a lot of anticoagulant issues, which is not necessarily unusual nowadays, but it's certainly not an average outpatient or ASC type of endoscopy unit.
So for these high acuity patients, do you find that they present more often with things like suboptimal prep, especially those nursing home patients? How does that overall sort of factor into your daily colonoscopies?
Well, unfortunately, it impacts us a great deal on almost a daily basis. Very often the nurses are so overwhelmed upstairs that they just don't have the time to really push that patient to consume their bowel prep the evening before. The patients, whether it's altered mental status or dementia or just not feeling well, it's very difficult to get them to complete a bowel preparation as an inpatient. And surprisingly, even in patients who have nasogastric tubes or PEG tubes, where it should be very easy to administer a bowel prep, You'd be surprised how often we have suboptimal preps. And there may be narcotic use or other variables at play there, but there's really no doubt that the majority of our inpatient bowel preparations do not match the outpatient preparations.
Do you find that there are issues even with the outpatient patient population, that there are issues with prep in general?
Of course, there's still patients who are either just simply non-compliant or did not understand the instructions, or again, we do have a lot of patients who have pretty severe constipation, whether that be idiopathic or drug-induced. So it's a problem there as well.
Got it. Yeah, and I saw on your website that you actually made a video to cover colonoscopy, and particularly you obviously stressed the importance of the prep, and that being almost the worst part of it all.
Right.
Is that day before, which I think resonates with a lot of patients that have gone through it before. So kind of switching gears a little bit here. So obviously we understand your patient population, but how do you think about peer review for your patients then? Do you have any sort of protocol in place for your more emergent cases, let's say, or do you have certain predictors of inadequate prep that you use? And how do you kind of decide who gets the peer review
Sure.
system?
Well, we haven't had peer review for very long, so I wouldn't say we have a true protocol. It's really a fly by the seat of your pants kind of approach, I think. Based on the financial aspects of it, obviously we focus on it for our inpatients in different arenas, but that's the primary focus. If we have already heard from the nurse earlier in the morning that the bowel preparation wasn't completed, or that certainly the results do not look promising with very thick or still fairly semi-solid stool, we're more likely just to have the peer review set up from the get-go. We don't waste our time going in there and then taking out the colonoscope and setting the system up. Unfortunately, we often get bad information. We were told the bowel preparation seemed very effective, not what we found or encountered in the colon. So at that point, we of course will stop, and fortunately it only takes a few minutes to set the device up and proceed. The majority of these, of course, are elective colonoscopies, or I should say semi-emergent colonoscopies. So certainly there's no issue with delaying. We have tried it for a few other indications, if you will. Its utility for a bad bowel preparation is pretty apparent. What I've enjoyed using it on actually are the GI bleeders, where I now have an opportunity to get in there on the day of admission rather than losing that day to a bowel preparation and waiting till the next day. If it's a diverticular bleed, we all know that if the colonoscope is not in the patient at the time of the bleed, it's unlikely you're going to define where it was or offer any kind of clip therapy. It's just better to get in there sooner. Of course, that can shorten the length of stay, hopefully would reduce the need for any blood transfusions. But it's nice to be able to do that, on day one. One of my partners used it on a fecal impaction. Really was an entire colon issue, but that was a little time consuming. But considering the patient historically had always gone to the OR for repeated events like this, it was nice to have a different approach that kept that particular patient out of the operating room.
Yeah, I can imagine that being a challenging case for sure. But I'm sure the patient was excited to be able to be, done and done in the lab and not have to go to the OR for something like that. And I like how you mentioned the reduced chance of a blood transfusion as well, because regularly about PureView being able to maybe save on length of stay, but there's other ramifications as well with that time savings, if you will, on things like that. So the other thing you mentioned was that you seem to communicate with your nurse frequently. Now, does your nursing staff round on these patients to communicate with them about how the prep had gone and what the effluent might be? How does that whole scenario play out, and how do you kind of decide whether you'd send a patient down or not?
Generally, the way this works is that our endoscopy nurses will call for a report early in the morning on all the inpatients slated for that day to make sure there are no issues to contend with. If there is a question, the nurse can't quite give us clear information on the floor. We do have inpatient physician assistants who will then go up and assess the patient in addition to their usual rounding and consultation duties. But most of the time, it's nurse-to-nurse communication from the floor to the endoscopy unit.
Well, great. And just sort of to sum things up a little bit, so can maybe you speak to, I know you spoke to the fecal impaction case that you or your colleague had. Are there any other cases? I know you had mentioned, potential bleeders and things like that, but any cases that you'd maybe want to highlight that you've had some success with the PureView system?
Well, I mean, number one, that fecal impaction case, that was a success. I'll be honest, it took a couple of hours, but better my partner than me. But that was definitely a success where, it's pretty off-label, if you will, but it was effective. We've had a couple of bleeders. One, we were able to identify the bleeding diverticulum and treat on the spot. Another patient where I was convinced it was a diverticular bleed. It turned out it was not. It turned out just to be extremely severe ischemic colitis. But at least we now knew that immediately rather than losing a day with it. To me, the bread and butter approach, of course, will always be the suboptimal bowel preparation to see what you're looking at. And I think the second most useful group will be in the bleeding patients. It's actually pretty effective. Generally I would say using the device adds 5 to 10 minutes to the procedure. For cases where I anticipated needing it, it was already attached to the colonoscope. Usually 5 to 10 minutes is about all that I think it adds to the procedure. The more stool there is, of course, the longer it'll take. But really, I expect it to be more time consuming than it really is. The endoscope, of course, handles a little differently, but I've not had any cases where I could not reach the cecum or had what I would consider any significant difficulty advancing the colonoscope.
That's very helpful. And I know that, those that are evaluating PureView or thinking about bringing it on, I mean, those are the questions that they often ask, is how much longer is this going to take me? Obviously, these patients are already pretty dirty in general. So even if you tried with let's say the naked scope, it may take longer anyways.
Correct.
But no, I'd say that's about average. I'd say people say it adds about 5 to 10 minutes, and navigation it's one of those things where it's true. You're used to just driving a regular scope all the time. This is going to feel a little bit different, but something that most can kind of adjust to very quickly, being a regular endoscopist. So
there's a little, because of the overtube, that you feel the resistance, if you will, as the scope's advancing. But At other times, it almost seems to be helpful. With that sheath on, it's less likely to do coiling at the flexures, for example. So I have yet to need any external abdominal pressure from the nursing staff to prevent endoscope looping, because it actually solves that problem. So you could argue it helps you as much as it hinders you in terms of getting to the cecum.
Well, that's great to hear. And again, very good feedback and much appreciated. So that's all we had for you today. We really appreciate you taking the time. I think it's been a great conversation. I've learned about your practice and sort of your stance with peer review. But again, we really thank you for your time.
My pleasure, and thanks for your excellent support.